Welcome to Podcasts on Demand, a continuing medical education activity. This activity includes the most recent and current clinical data presented by leading experts. If you are seeking continuing education credit, please review the disclosures and the requirements for successful completion of the activity prior to listening to the podcast. A link is found in the podcast description that can direct you to this information.
Hello, I'm Dr. Anton Pozniak. I'm a consultant physician at the Chelsea and Westminster Hospital in London, the UK, and welcome to Clinical Clips from Glasgow 2024. It's day 2 of 2. I'm going to talk today about some very interesting data that was presented at the conference, and I think the first part of the data is about lenacapavir in PrEP. And as you know, at IAS this year, it made a big impact, the Purpose 1 study, the use of lenacapavir in PrEP, given 6 monthly to cisgender women, and they found no transmissions. So Linda Gale Becker gave a little more detail on this study today, and I think it's very interesting what came out of this, and they looked at persistence, annual persistence. Now, the main thing to know is that there were 3 groups, one with lenacapavir active and placebo tenofovir, and then with placebo lenacapavir, and another group with active FTAF, and another group with placebo lenacapavir and active FTDF. And so everyone had an injection, everyone had to take pills. But how did they persist with the injections and with the pills? Now, interestingly, the adherence to injections was high, while the adherence to the oral FTAF and FTDF was poor. And actually, when you looked at the people who acquired HIV, FTDF, over time, their adherence declined. However, when you looked at them taking injections, even their placebo injections, it was about 82% in the FTAF, 76% in the FTDF, and in the LEN, nearly 80%, they took the injections. So this was quite fascinating, actually, that people carried on with their injections, but declined with their tablets. And when they looked at it overall, the persistence, as I said, with the active LEN was 79.5, but those who took all of their pills was only around 5%. And obviously, we know that both FTDF and FTAF, as taken as PrEP, if it's taken at least 4 times a week in men and women, that it works. But in this trial, when you took injections and pills, the injections were preferred over the pills. As I say, the results were quite astounding, seeing no transmissions. But then what happens if you then capavir in cisgender, gay, bisexual and other men, transgender women and men, and gender diverse people? And that was the subject of a second presentation called Purpose 2. So this was a similar design. However, this group of subjects were randomized to lenacapavir every 26 weeks and oral FTDF, a placebo, or they were given FTDF and subcutaneous len placebo. And the interesting thing is there was no FTAF in this. So what happened to this group in terms of prevention? Just to say that, again, we saw a very low HIV incidence in the participants receiving len, and it was 0.1. There were 2 infections in this group out of nearly people on the len. The background HIV incidence was 2.37, the incidence on len 0.1, and on the FTDF 0.93. So it appeared that this group did get some benefit of FTDF, but nothing like it seemed from the injections. The other thing to say here is when you look at the adherence to the len injections, it's very high and consistent. But again, the adherence to TDF started off to being high and actually declined over time. There are a few things to say, really, that I'd just like to comment on. Should we keep len just for PrEP and not for treatment? This has been discussed at the conference. Also, the assay they use for background incidence of HIV, the recency assay, what does that really mean? And also, you have to be aware that some of the patients in Purpose 1, in between basically screening and getting the first infection, about 7 of them developed HIV. However, on injection, on therapy, and nobody in Purpose 1 developed an infection, and in this Purpose 2, 2 people did. Now, I want to switch tack a little bit now to a very interesting study that was run by the French group, the ANRS, called OncoVIH-AC, the CO24 cohort study. I thought this was an excellent study, and it was about the use of immune checkpoint inhibitors in cancer management. So they looked at patients got cancer given these drugs. And why is that important? Well, these drugs could disrupt immune tolerance. They could cause a risk of immune-related events being worse, and they really didn't have very much data. And I did hear from some of the delegates that it was quite difficult for HIV patients to access these because of the concerns over the interactions. And the interactions are immunovirological. That's what they're proposed to be. They're not drug-drug interactions. They really shouldn't see very many of those at all. They had patients who are HIV positive, who'd been diagnosed with cancer, and were given immune checkpoint inhibitors for the first time. And they looked at grade 3 events that were immune-related. Now, being given these drugs, most of the cancers were lung and head and neck. Some had melanoma, liver, and Hodgkin's disease. And their overall CD4 count was low at about 117, varying between the interquartile range 51 to 280. So these were pretty immune suppressed to start with. And you can see by adding an immune checkpoint inhibitor, there might be concern that you'd get more immune-related adverse events. Well, overall, they had 34 more equal to or more than grade 3 immune events in 20 participants. And this is very similar to the background rate. But what increased your risk of these amongst this group was having a low CD4, history of surgery for your cancer, interestingly positive CMV serology, and also having HIV for a very long time. And maybe all of this is related to a lot of immune suppression, and then you get the immune checkpoint inhibitor, and that may increase these problems. Interestingly, use of nivolumab improved this, and you got less problems with immune-related adverse events. When you looked at the Nadir CD4, basically there was very little impact on these immune checkpoint inhibitors on CD4 or viral load. So overall, the incidence of the first episode of grade 3 or more of immune-related adverse event was about 15% of a year. And in fact, this when you look at all the severe episodes, it's 26.9 per 100 person years. Why am I saying this? Because in the general population, these things occur between 5 and 30%. So there's really very little difference between this HIV population given immune checkpoint inhibitors and the general population. And I think now we can have some confidence, because it's quite difficult to do these studies, finding patients with HIV and cancer and given these drugs. We can really start to say with confidence that actually our patients who need these drugs, obviously we have to look out for these reactions, but there's no reason not to think about treating them if that's appropriate. So there are lots of things to see and catch up from Glasgow. But I really think that the lenacapavir in PrEP is a very important aspect for us to keep watching closely. And I'm glad that the immune checkpoint inhibitors look as safe as the general population or HIV population. And I'd like to thank you for joining us for this series from the 2024 Glasgow conference. And can you please refer to the landing page for slides and to claim your continuing education credit, as well as view the previous clinical clip from day 1.
We hope you found this podcast useful and educational. To receive continuing education credit and to download your printable certificate, please go to the activity page at practice.cme.com to complete the post-test and evaluation to receive continuing education credit.